Comprehensive Primary Care CPC initiative worked to improve care, improve health, and lower costs for patients and their families in the primary care setting. Nearly 500 primary care practices and more than 2,000 practitioners were enrolled in CPC from 2012 to 2016. The CPC initiative focused on 5 functions of primary care: access and continuity, planned care and population health, risk-stratified care management, patient and caregiver engagement, and coordination of care across a medical neighborhood. This on-demand learning series explores how CPC practices implemented strategies designed to strengthen primary care.
My husband is Dr. Randy Walker. Of course, we're located in DeQueen, Arkansas. Originally, we started out with one physician. We added a nurse practitioner approximately 2.5 years ago, and we just recently added another nurse practitioner. So now we're at one physician and 2 nurse practitioners. We have an impaneled patient load of 5,900. One of my AFMC reps said, "Why don't you join this Arkansas Chronic Illness Collaborative?" And this was a collaborative that was focused on studying specific diseases, and it was diabetes, hypertension, or preventative medicine or cancers, and you could pick one of those. I decided to pick diabetes. So I'm sitting down and I'm looking through my EMR and I'm running my numbers, and of course Dr. Walker's saying, we have to have 100 diabetics to be in this program. We don't have 100. We can't participate. We only have about 50, and the 50 that we have, they're all doing really good. They all tell me they're doing fine. We're not having any issues. And so I thought, well, just for kicks, I'm going to go ahead and just run these numbers. I had never ran data within the system before. That was new to me. So I sat down and ran the numbers and then reran them again and reran them again. We didn't have 50 diabetics. We had 300 diabetics. They weren't doing 100%. We had about 50% of them that had a hemoglobin A1C that was greater than 9. And so that was a very eye-opening moment for us. I would say in that moment, we kind of had 3 epiphanies. Number one, I was addicted to data. I don't think anybody else is, but I was. And I knew that from now on, any decisions I made about the practice and what we were going to do and the things that we were going to offer were going to be based in data. 2, we recognized the importance of a team, because there was no way that my provider was going to be able to manage all of these things that were going on as far as population health and clinical quality measures and standing orders. And the third was the value in processes, in that it empowered our staff. That was kind of a critical time for us. So at this point, I'm going to kind of show you what our staff looks like right now. This is Team 1. This is going to be Dr. Walker's team. Dr. Walker has 4 care managers, and what we do is our nurses are trained in a dual role as far as nurses, but also care managers for those patients. And then we have 2 care coordinators who are kind of behind the scenes and setting up the program. He also has a MA and an X-ray tech. One of my X-ray tech that you saw on Team 1, she manages all diagnostic imaging out of the office and in the office as well. The care coordinator who manages the home health patients, she also manages all referrals as well. All of our employees have dual roles. As you can see on that right-hand side, we've got our CDSS alerts. These are going to be our clinical decision support tools, and pretty much the providers pick those tools to mirror our clinical quality measures. We're flagging those patients who need a shared decision-making tool, or we're flagging those patients who need a pain med contract, immunizations. We have several things that are in office as far as hemoglobin A1C, lab, PT and INR, and what have you. And so those things are done prior to the physician going in, so that when he's going in, he actually has a number in front of him. On his team huddle, he actually has the entire office. So we have representatives from immunizations, we have billing, we have the front desk girls. Pretty much there's someone from every department in there. Used to where we were looking at and identifying, okay, who needs a shared decision-making tool, who needs an A1C. Now all that information is on that CDSS alert. Now what they're specifically focusing on is, again, those patients that are high risk. Why are they high risk? What made them high risk and what needs to happen today? My provider really doesn't go in the room without a care manager. This way, I've got my care manager in there. You know, my provider may be dealing with the fact that your blood pressure is out of control and you're having some issues, and he can deal with that, and he can rewrite your medications and make those changes and suggestions, and then he's able to go ahead and move on to the next room where my care manager will actually say, okay, you haven't had your mammogram, let's go ahead and set that up. And then also confirm that all of their prescriptions went correctly, and then make sure they understand how many they have and where they're at. We don't want our care managers rushing from patient to patient to patient. We really want them spending a good quality amount of time with that patient. We want to make sure, again, that that patient is caught up on their health measures, understands their prescriptions, understands where they went. If you don't spend that time with that patient, then you're going to spend that time on the phone with that patient. It's worked much better for us to invest the time while they're here and in the clinic versus 100 phone calls after they've left. Adding that care manager going in the room with him allows him to be engaged with that patient. It's not tying him to that monitor. It's not tying him to that mouse or to that keyboard. I can tell you that it has increased the amount of patients that he can see. We have overall better care for our patients because they have an engaged staff. They have engaged providers. We've definitely seen an increase on those measures that we're tracking as far as getting our diabetics in for LDL, controlling high blood pressure or lipid for our IVDs. We're seeing our patients with a hemoglobin A1C greater than 9 decreasing, which I'm very ecstatic about. We set internal goals in the office. We have a huge board that sits in the hallway, and it shows all the measures that we're monitoring them. We have monthly data in them, and then at the end of that, we have a goal for the clinic as far as where we want to be. I think it's had a wonderful effect on clinical quality measures.
For more information and resources, visit the Comprehensive Primary Care Initiative webpage. Go to innovation.cms.gov and search for the CPC Innovation Model. This has been a production of TMF Health Quality Institute.